Hey, Mr. Sale.
Hey, hello.
Good evening.
Evening.
Hi,
John.
Mr. Xiao.
How are you? Hi.
Hi, Mr. Xiao.
David. And
Tianming is here as well. All three of us are here.
you're all together, is it?
Yes, yes. Dr. Bennett is here and Warwick is here as well. So most of the
Okay.
panelists are good to go.
Just 1 minute.
John?
So
John?
you better
Hello,
advertise.
Hello, Dr. Warlocks. Good to see you.
Hi, Wan. How you doing?
Wan. How you doing?
Good, good. Evening.
This is
Well,
Warlick's. She's going to run the show today.
Fantastic.
Yeah, she's a neurosurgeon from Thailand.
Run the show today.
It's so echo.
It's a neurosurgeon.
I'm having internet problems in Miami, Wan, so I'm connected with my
I'm having
smartphone.
internet problems in Miami, Wan. So I'm connected with my smartphone.
But so
Dr. Bennett,
Warlick,
you may have to turn the sound of one of your devices off.
yeah, I know.
So Warlick's is,
Reverberate and reverberate.
Is it driving you
yeah, I
nuts?
know.
Okay,
I'll get off it.
Okay, very good.
Very good.
Okay, Wan,
Yes.
did you get the emails, promotional emails?
Yes, I did.
Yeah, I put you on the list. I guess you weren't on the list before.
Okay.
Maybe not, but you'll get sick of those emails. I send out, but the way I figure it is, if you really want them, you don't mind. But if you don't like him, you just unsubscribe.
Yeah, yep.
So
Well, you can select what you like and what you don't like, you know.
yeah.
Mm.
Say Warlick is the artist that does the banners for our websites.
Yes, thank you very much, Dr. Warlocks. And I think, yes, Dr. Kate tells me that she also knows you. And, I said, yeah, at some stage, we're going to get you to help out with the Asian Oscillation Society as well to, help out with things. Maybe even do a new website, design a new website for us. Yeah.
Sure, of course.
Yeah.
I know it's okay. Yeah.
Good. But you also must spend some time studying your neurosurgery,
Excuse me for a minute. Go ahead. Okay.
Okay. So good. Thank you. So you're going to run the whole show for us? I'm just going to be in
the moderators will be Dr. Kate, so just wait. So we just only get introductions to Dr. Kate and introduce her as the moderators. That's all. Yes.
Okay. Still good. Yeah. And they see a female face, the next time they will want to subscribe more to.
Yeah. So I know her from the articles that we wrote together about neurosurgeons. Yeah.
Yes. And do you think there'll be some more people from Thailand who are going to take part today?
Actually, in my countries, the webinar things and all, I think is not that famous, but I just introduced to them, but I don't know how effective, it is. Yeah.
I think I sent initial earlier posters to the head of the Thai College of Neurosurgeons. What's his name? Dr. Wait, let me see. Wait, no. Dr. Yodrop Praset.
Oh, he's a senior teacher here.
Yeah.
Yes.
He's the president of the Thai College of Neurosurgeons, I think. And yeah, I got some old friends there. Dr. What's his name? Who's the general now in the army? In the army hospital.
Army hospital.
The
Yod Rat. I don't know.
Like young, old, a bit older.
A bit older. Sirarut.
Cedar Road, Cedar Road.
Oh yeah,
met him.
I met him. Yeah, on the Saturday we talk about this. Yeah.
Okay, good. I know him for many, many, many years. I even met his father before. I'm very old now. Good. Thank you for helping us and getting involved.
No, it's not at all. It's like side job besides do things besides surgeries anyway. So yeah.
Very good. Okay, so we wait for Kate. Maybe I text her.
Hi, Warlick, can you hear me?
Yes, I hear you.
Oh, okay. So basically, in 10 minutes, basically you say this is a new neurosurgery residence group, young neurosurgeons that basically want to cover the basics. And then basically I'd like to introduce Kate Brumman.
Okay.
Okay?
Okay.
Okay, in 10 minutes. Okay? Yeah, once again, I fell off the desktop.
Yeah.
It's good. It's a good thing you came.
Yeah, thank God I finished case early today, so you can ask me. I'm not going in.
Yeah, that got lucky. I'm glad you checked in.
Good. I'm glad you're here. So you can also take part in some of these webinars if you like. Because the Asian Oscillation also organizes quite a few of these meetings, so webinars as well. So yeah, more than welcome to come.
I think Jai is here. Hi, Jai. Hi, Prof. Drummond.
Hi, Jai.
Hello.
Prof. Kate here.
Hey, how are you?
Hi, Professor Kate.
Hi, Kate.
I want you. How are you?
Hi, Kate. We're good. Thank you for staying up late for us. It's 11 o'clock in Melbourne.
I tell you, it's very difficult.
But you ladies are, the people that keep everybody else going here in this part of the world. So
Somebody's got to.
yes, agreed.
So how are we going to run this, guys?
I think Dr. Warlux is going to introduce you, and then you can start doing whatever you know best.
Yes. So I will introduce the name of these webinars, and then I will introduce Professor Kate and provide you as the moderators, and then you can continue. Yeah.
Okay. And we're planning to run for about an hour. Is that right?
Yeah,
Total?
I think they're all going to give about 15 to 20 minutes talk, and then whether you want to have the questions in the middle or actually at the end, that's really up to you. There might be something very pressing that you want to ask. We can always do that first.
Probably questions after each topic. So how are the questions coming up? Are they coming up in the chat, or how are we running questions?
I think we can ask people to ask questions in the chat and
Okay.
among the panelists in the Q&A if they want to as well. Yeah.
Oh, I see. There's Q&A there.
Hi, Dr. Drummond.
Hey, how are you?
Yeah, I'm having bad connections in Miami. Warlix is going to run the show, and we get the questions from the chat, or people can ask them directly, whichever you prefer, or whatever.
Okay. The chat's fine.
Yeah, we can bring it to your attention. Like Warlix, we can either say there's a question here on the chat. So sometimes people ask a lot of questions, sometimes they don't. So we'll just try to keep it rolling. Warlix is an expert at smoothness, smooth production.
He's an expert at a lot of things.
Yeah. Okay, 6 minutes we start.
Oh, so it's gonna run at 7. Okay, I see. So it's on.
If I keep my smartphone away, I don't have the interference. That drives you nuts, I'm sure. Let me get off this.
Oh, I don't know, honey.
So all of the speaker coming through the panel. John? Oh, he's lost his connection.
Speakers are all here. I think only Jai is one of the mentors. I think there's another one, Colin, but he might come later because he's only covering the spinal trauma talk.
So we've got Cheong Ming speaking first. Yes.
Yeah, and Dr.
Yeah,
Rao.
I'm here.
Yeah.
Okay, the first couple like coming up.
And Lim Zhu.
You call me
Okay,
Jiaxi.
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 So your names are a bit difficult, but
Okay. What do I call the first speaker?
Tianming.
Yeah, you can call me Tianming.
Yang Ming.
Yeah.
Okay.
Yeah.
All right. And then the second speaker I'm calling Jiazu.
Sounds pretty good to me.
Yuzu,
Okay.
Yuzu, no.
Oh,
Jiaxi.
thank God for David Mack.
Yes.
I will do my best.
You're doing a great job. Thanks for moderating, Rocket.
You're welcome. You're welcome.
Tianming was telling us that when he was a medical student, you were very kind to him in Melbourne.
Oh, really?
Yeah.
It must have been a good day. When was that? How long ago were you a medical student in Melbourne now?
I think that was 2011. That would be 2011.
Wow, that's a while ago, huh?
Yeah. I think you showed me your immunofluorescence. Not immunofluorescence, the ALA on the microscope.
Oh, gee, we must have been just starting to use it then.
Yes.
Yeah,
right.
2011. I think that's the year we started to use it. Oh, that would have been exciting then.
Yeah, that's right.
That's
Probably
why
one
you're
of the
happy.
because I can't remember. Yeah.
Well, she was happy because Andrew was still running the show, and therefore she didn't have. Well, she had a lot of responsibilities.
What are you
because of
talking about? I just had to do what Andrew said. It's easier now. I get to make my own decisions.
That's true. That's true.
Then I just get the call. Kate, fix this.
Yes, and you're the fixer.
I just fixed it. That's right. Exactly right.
Okay, Warlick's 2 minutes, okay?
Mhm. I'm going to go into silence now. Thanks everybody for coming here and for getting things done. And John, thank you. Warlux, thank you. Kate, thank you so much.
You're welcome.
So far.
Okay, Warlick's anytime now. Okay, Warlick's.
Okay, Warlick's.
Okay. You don't have to count down, right?
Whatever you want to do. You develop your own style. Make some funny faces.
Okay, hi everyone. Welcome to the Neurosurgical TV. Today we have a new webinars launch. It's the Neurosurgical Bootcamp. It's the webinar from residents to residents, fundamentals in neurosurgeries. Today we have our guest moderators, Professor Kate Drummond. She is the neurosurgeon from Australia. She works at the Royal Melbourne Hospitals. Please welcome Dr. Kate.
Welcome, everybody. Thank you very much for attending this first of the neurosurgical boot camps from the National Neuroscience Institute in Singapore. As Warlick said, this is going to be by residents, for residents. We've got 3 topics that really are of interest to anyone aspiring to be a great neurosurgeon. So we've got 3 topics which will be presented over the course of about 15 or 20 minutes. And if you have questions, then if you could put them into the chat and we'll endeavour to answer them. And if you don't have questions, then I'll make some up that are probably even harder. So you better be kind to the speakers and come up with some nice questions. So I'd just like to introduce our first speaker, who is Tien Meng. And he's going to speak on principles of intracranial pressure management.
Okay, hi, thanks, Dr. Kate. Yeah, I'm Tien Meng from Singapore. I would like to thank everyone for attending this talk. I'll share my screen now. Okay, yeah, can everyone see? Okay, great, yeah. So today I'm going to talk about the principles of intracranial pressure management. So what I'm going to go through today, firstly, to understand the pathophysiology of raised intracranial pressure, to know the methods of monitoring intracranial pressure, to describe the management of intracranial pressure in the setting of traumatic brain injury. So firstly, what is intracranial pressure? So intracranial pressure is defined as the pressure exerted by intracranial contents on the skull. The normal intracranial pressure in the range of 5 to 10, with more than 20 millimeters mercury considered pathological. And this is a very important principle that we need to understand when we're managing patients with high intracranial pressure. Basically, the Monroe-Kelly principle states that the skull is of a rigid space containing brain, blood, and CSF. Any increase in any of the compartments can be compensated without a raise in ICP. However, when the compensation fails, as we can see over on the figure, ICP can raise exponentially. So what causes a raised ICP? Raised ICP can be caused by any increase in any of the intracranial contents, namely the brain, blood, CSF, and also any pathological mass in the brain. Any increase in brain can be due to cerebral edema, which can be cytotoxic or vasogenic edema. Increase in blood can be due to defective autoregulation, such as hyperemia after a post-AVM resection and in traumatic brain injury, and also in cerebral venous thrombosis when the venous outflow is obstructed. Increase in CSF can be caused by hydrocephalus, and also any pathological mass such as tumor and blood clot can cause a raise in ICP. So why is it a problem? Well, when the ICP initially increases, it can actually decrease perfusion pressure, and that if blood flow actually is low enough to and it can't meet the metabolic demands of the brain, ischemia can occur. Further increase in intracranial pressure, especially in one particular component of the brain, can actually force the brain out from one component into another component. And when that happens, what we can notice in the patient is herniation syndromes, which I will go through a bit later. Yeah. So what are the clinical features of raised ICP? So patient commonly presents with headache, classically a headache that's worse in the morning, nausea, vomiting, drowsiness, and somnolence. When we examine a patient, we usually find that the GCS can be slightly depressed. There will be abnormal pupillary reaction, which I will go through later. There can be papilloedema, but however, this is more common in the setting of chronic raised ICP, in the setting of tumor and benign intracranial hypertension. In acute raised ICP, this is not so common. It can also be sixth nerve palsy. As we all know, that abducens nerve has the longest intracranial course and can be very susceptible to stretching damage due to the raised ICP. Also with raised ICP, there can be weakness or abnormal posturing, which I will describe later. So when we are managing patients with raised ICP, it's important to understand and to interpret the ICP waveform. A normal ICP waveform consists of 3 waves, the P1, P2, and P3. The P1 is a percussion wave, which corresponds to pulsation of intracranial arteries. P2 is a tidal wave, which is actually from the rebound from brain elastance. And P3 is a dichotic wave, which corresponds to that dichotic notch in arterial waveform. A rising P2 component can signify that the brain is becoming less compliant. As we can see in the pressure volume curve here, in the flat part of the curve, the waveform will be as such, where the P2 component is higher than P1. As the brain starts to lose its compliance, P2 will actually go above P1, and in this setting, any small increase in intracranial content volume can lead to large change in intracranial pressure. So we go through the herniation syndromes. This is what happens when high intracranial pressure in one compartment of the brain forces the brain into another compartment. Firstly, you can look at this is the subfalcine herniation. Is when the cingulate gyrus herniates under the fork cerebri and compresses the anterior cerebral arteries, causing anterior cerebral artery territory infarct. An uncal herniation can cause compression of the oculomotor nerve, leading to unilateral pupillary dilatation, and also compression of the ipsilateral crus cerebri, leading to contralateral weakness. With transtentorial and tonsillar herniation, there can be extensive damage to the brainstem, causing bilateral fixed and dilated pupils. And lastly, as a very late sign of raised ICP, is a Cushing's reflex, and patient can manifest with hypertension, bradycardia, respiratory irregularities, and they are usually sign of brainstem injury. We also must remember that raised ICP is a very important component of secondary brain damage in setting of trauma, and it should be managed appropriately. So how can we monitor ICP? It can be monitored via invasive and non-invasive methods. So for invasive methods, there is a ventriculostomy, intraparenchymal monitor, subdural, epidural, and also subarachnoid monitors. Non-invasively, there is TCD ultrasonography of derived pulsatility index, which is seen on the picture on the left side. And on the right side is ultrasound measurement of optic nerve diameter. But the methods of monitoring that we commonly use in clinical setting, the two most common are external ventricular drain and intraparenchymal monitor. The advantage of external ventricular drain is that it allows therapeutic drainage of CSF. It can also be re-zeroed anytime at bedside. The disadvantage, however, is that it requires a free-flowing column of CSF to work. So if there is any blockage of the EVD, whether by blood or by debris, the ICP actually can't be read. There's also increased risk of catheter-associated infection and ventriculitis with prolonged EVD use. For intraparenchymal monitor, it has advantage in the sense that there is less risk of infection. It's easier to be inserted, and also certain intraparenchymal catheters comes with multi-modal monitoring capabilities. The disadvantage is that we are unable to drain CSF for therapeutic purposes. And also they experience zero drift, which with prolonged use of ICP, they can be less accurate. So when do we monitor patients? Well, the Brain Trauma Foundation guidelines suggest that we monitor patients to use the information from ICP monitor to manage patients with severe brain injury. However, in our institute, we monitor patients where we find that reliable neurological examinations cannot be performed, or who patients have abnormal CT scans who are at risk of raised ICP. So what are the goals of ICP treatment? The goals of ICP treatment is to maintain cerebral blood flow and also to prevent herniation syndromes. The target that we usually try to achieve is a cerebral perfusion pressure of 60 to 70 and intracranial pressure of less than 22. And this is from the latest Brain Trauma Foundation guidelines. So what can we do to treat ICP? Well, ICP management can be performed in a stepwise protocol manner. And the steps are arranged in increments of risk and intensity. So it's always important to remember that whenever ICP is not sufficiently controlled, we have to review and optimize the current tiers of therapy and consider a CT brain to exclude new or developing mass lesions that may be surgically evacuable. If there is no surgical mass lesion, then we can consider escalation to the next tier of therapy. So for tier 1, this can be implemented in all patients with a severe traumatic brain injury with a risk of raised ICP. The patient should be maintained with a saturation of more than 95%. Cerebral metabolic requirements should be decreased with the implementation of sedation, analgesia, neuromuscular blockade, and aggressive treatment of hyperpyrexia. The patient should also be nursed with the neck in the neutral position and head up in a position of 30 to 45 degrees. This optimizes venous drainage, but also maintains CPP. Patients' glucose should be tightly controlled. The PaCO2 should be maintained in a level of 35 to 40, and seizure prophylaxis should be given. And any seizure should also be treated aggressively. This is an example of a patient with severe traumatic brain injury. As we can all see, the patient is nursed with a head up in about 45 degrees and neck in neutral positions, and also intubated to decrease cerebral metabolic activity. So what happens when the ICP still can't be controlled? Then we can move on to tier 2 therapy, which consists of hyperventilation, hyperosmolar therapy, CSF drainage, and mild hypothermia. Hyperventilation works by decreasing CO2, which causes vasoconstriction, which reduces ICP. The disadvantage of this is that there is risk of ischemia, and it only brings about a short-term benefit as the body quickly compensates with metabolic acidosis. It should only really be used for as a bridge for more definite treatment, or only with monitoring of brain tissue oxygenation. So the recommendation by the Brain Trauma Foundation guidelines, the main recommendation is that prolonged prophylactic hyperventilation with PaCO2 of less than 25 millimeters mercury is not recommended. Osmotherapy consists of mannitol and hypertonic saline. Mannitol works by improving deformity of red blood cell, leading to reactive vasoconstriction, thereby reducing ICP. These are the early effects of mannitol. In the longer term, mannitol is an osmotic diuresis, and therefore causes a sustained sustained effects in ICP control. Side effects of mannitol is hypotension and hypovolemia, and renal failure if the serum osmolality rises above 320. Hypertonic saline comes in a few forms, 3%, 7%, and 23%. It works by being an osmotic agent that draws fluid from the brain. It can be given in either a bolus manner or as a continuous infusion. There's, however, no evidence to suggest that one therapy is superior to the other in the management of ICP. For CSF drainage, it can achieve a rapid reduction in ICP, and we must understand that when we're dealing with patients with raised ICP, we are working in a non-compliant part of the pressure volume. Therefore, even a drainage of very small amounts of CSF can actually cause a large change in intracranial pressure. Hypothermia works by decreasing CMRO2, and it does so by 6 to 7% for every drop in body temperature. And at about 18 to 20 degrees Celsius, burst of pressure occurs. The side effect of hypothermia prophylactic hypothermia is not recommended.
Could everybody mute?
Yeah.
Okay.
Based on the latest Brain Trauma Foundation guidelines. So moving on to the third tier of therapy, one of it is barbiturate coma. Side effects is hypotension, hypokalemia, and increased risk of infection. It can be given in 250 milligrams bolus with an infusion of 4 to 8 milligrams per kilogram per hour to achieve and to maintain burst suppression. The goals of barbiturate coma is ICP control, or when it should stop when side effects occur as well, or when burst suppression EEG happens. When the EEG is in burst suppression, the brain is at the minimal metabolic state, and therefore any increase in the dose of barbiturate coma will not have any beneficial effects in ICP. There's two articles that show evidence for the use of barbiturate coma. Eisenberg in 1988 shows that barbiturate coma improved the chance of ICP control by twofold. However, a Cochrane review in 2012 shows that although ICP can be controlled, but it does not reduce mortality, but in fact increases the risk of infection. Therefore, the recommendation by the Brain Trauma Foundation guidelines is that high-dose barbiturate coma is only recommended to control elevated ICP, refractory to maximum standard medical and surgical treatment. Hemodynamic stability is essential before and during barbiturate therapy. Yeah. So lastly, decompressive craniectomy in the setting of raised ICP. So it is a hotly debated topic, and two articles tried to answer the question. And basically, this one is an article published in 2011, the DECRA trial, and also the Rescue ICP trial in 2016. Yeah. Based on the results of both of these trials, the Brain Trauma Foundation guidelines recommended that for late refractory ICP elevation, secondary decompressive craniectomy can be performed to improve mortality and favorable outcomes. However, for early refractory ICP elevations, it is not recommended. And if it is performed, a large frontotemporal parietal decompressive craniectomy is recommended over a small decompressive craniectomy. So in summary, increase in one component of intracranial content can be compensated by decrease in others. When the compensation fails, ICP rises. And ICP can be monitored to guide the management of raised ICP. Management of raised ICP should be performed in a stepwise protocol, and we should always review and optimize the current tier of management whenever ICP is rising, and also to consider CT brain to exclude surgically evacuable mass lesion. And if there is none, we should escalate to the next tier of therapy. So that's the end of my presentation. Are there any questions?
So if anyone's got any questions, if you'd like to write them in the chat. Thanks, Tieng Meng. That was a great presentation, really good summary of the literature. So I noticed that you've said that you didn't think there was any difference between hypertonic saline and mannitol, and yet it seems as though all of the intensive care units have gone over to hypertonic saline. Could you expand at all on what might be the benefits or risks of either of them?
Well, with hypertonic saline, because it is less of a osmotic diuresis, so it can actually, theoretically, it can maintain intravascular volume and therefore maintain the cerebral perfusion pressure. That is one of the main advantages of hypertonic saline over mannitol use that I know of.
I think the other question is that perhaps if used repeatedly, if mannitol leaches out of damaged vessels and sits in the brain, it can actually draw water to it and make cerebral edema worse over time. That seemed to be the prevailing wisdom. I don't know if Dr. Rao, your mentor, has got anything to say about that, or...
Yeah, so I think it depends on the prolonged usage. So it depends on how we give it. I must say in our ICUs in Singapore, it depends on our intensivists. Some of the UK trained ones still go with mannitol, but our intensivists that have been trained in Australia are more comfortable with hypertonic saline. And personally, we have given them leeway in the protocol. But there has been more of a shift towards hypertonic saline to remove the rebound as well with intermittent boluses and to keep it as a continuous infusion.
I think it depends on your age as well. When you're starting to age like me, hypertonic saline didn't exist, so I love a bit of mannitol, but I must admit that there are some advantages for intravascular volume with the hypertonic saline. So I was interested, I haven't seen any questions, but I was interested to see the change in recommendations on decompressive craniectomy. So, you know, what are you guys doing in Singapore? How many decompressive craniectomies are you doing? And I don't mean leaving the bone flap out after evacuating a mass lesion. I mean a primary decompressive craniectomy.
Actually, if the ICP is not controlled despite best medical therapy, we do still do a decompressive craniectomy.
So when you've come to the end of all other options?
Yeah, that's right, yeah.
How often, what sort of percentage of head injuries would you be doing that in, roughly, do you think? Is it a common or an uncommon event?
It's actually quite uncommon.
Yeah, I would say we are doing less now since DECRA came out than before DECRA was. And I think the medical treatment is actually better done now as well, that the number of patients that we need to actually decompress is much lesser.
Yeah, I think it's become almost very rare now in Australia. But I wonder whether, you know, yeah, these things come in and out of fashion. I'm starting to wonder whether we're missing perhaps the odd patient who, you know, as they say, in a delayed fashion when all other mechanisms have been exhausted, that perhaps it might be something to do. I think you've got to think a little bit about the scan as well. You know, you can have raised ICP with a scan that looks moderately normal, and that might give you a little bit more hope of a good outcome than the raised ICP of a scan that's really, you know, got widespread contusions or you know, bilateral damage that might really lead to a bad outcome. Has anyone got any further comments on raised intracranial pressure or questions?
I believe that I have a questions asking from our panelist to the speaker. From the Dr. Muhammad, he asked a question. Is there any indication cystinotomies to reduce the ICP? And second question is, what is guideline for the best reduced ICP in severe head injury? Yeah.
So for the cystinostomy, it is not practiced in this institute, in my institute at least, and I don't think, I'm not sure if there's any evidence out there that supports the use of cystinostomy, to be honest. What was the second question again?
He asked, what is, I think maybe he asked like in the guideline, what is the best methods to reduce the ICP in severe head injury?
Yeah, I mean, I think it can be, it's common, therapies to reduce ICP can be implemented in a tiered fashion. I don't think there's a best or therapy in that sense, but generally, what we tend to follow is the recommendations from Brain Trauma Foundation guidelines.
So I'll just add that actually the best procedure to reduce ICP is a decompressive craniectomy, right? Because if you remove the Monroe-Kelly principle concept, then you understand that, but it does not mean that the reduction of ICP leads to a better outcome. So I think we have to keep in touch with the literature of the new modalities of monitoring that are coming out. So in Singapore, we've moved to an oxygen-tiered decompression idea, where even if ICP is normal and oxygenation is compromised, you may still need interventions for it. So I think the data that is coming out is shifting a little bit from just a pressure-related problem. And obviously with the AI algorithms that come out and imaging loading into that, I think we're in an interesting field in terms of looking at decision-making algorithms. And we probably need to pay more attention to that.
There, I've just got one more question. Does anyone carry out cystocystonostomy in surgeries with hemicraniectomy? I mean, I don't know that there's much evidence for any of those. Okay, so thank you, Tien Meng. I might move along now. That was a fantastic presentation. Really great summary of the literature and very well presented. Thank you.
Thanks, everyone.
So we'll move on now to Jia Zhu, who's going to talk about basic interpretation of CT scans of the brain. Now, I must point out that this was something that that flummoxed me for quite a long time as a junior resident. So I think getting a system for interpreting CT scans of the brain and practicing it is most important. So I'm looking forward to this. I might learn something.
All right, thank you very much, Tien Meng. Thanks, Prof. Kate. So good evening from Singapore. I'm Jia Zhu, one of the senior residents from NNI. And it's my pleasure today to present on the basic interpretation of the CT brain. So these are the topics I'll be covering today. So I think similar to Prof. Kate, you know, when I first started reading scans, it's not a very easy process at all. I made many mistakes, and I find that it's primarily due to me liking to overcomplicate things and focusing on things that are irrelevant. So thankfully, after quite a few years of guidance from seniors, from reading, I've learned some tips and tricks. So hopefully they'll be useful for you as well. Because of time constraints, so I'll just be mainly focusing on reading CT brain, plain CT brains, and I'll be focusing on trauma and acute neurosurgery. So before we start talking about the CT brain itself, let's figure out where in the decision-making process the CT brain features in, because what questions we ask ultimately determines what answers we get. When we first see a patient, we take a history, we perform an examination, we do some investigation, and that brings us to the impression that we have. And from that impression of what the patient may have, we derive a plan. So since we're all surgeons, the question we always ask is there any indication for surgery? Is there any contraindication to surgery? And if so, can I optimize it? Is there any urgency to perform the surgery? And how can I approach this operation? So obviously investigations, the scan is an investigation. With regards to indication for surgery, the scan can tell us whether or not there's a surgical lesion to take out. With regards to urgency, the severity of mass effect that is demonstrated on the CT brain, along with the patient's clinical status, gives us a very, very strong clue. And of course, with regards to approach, so for example, when we see intracerebral hematoma, the scan can give us some idea of should we approach it from a transcortical or transcranial approach, or perhaps even if something simple like is a subdural clot evacuable safely through only a burr hole. So all these questions converge onto the CT brain. So let's talk about normal, because everything that's not normal is pathological. So it's very, very important that we recognize normal. So as mentioned before, I tend to like to overcomplicate things. So hopefully at the end of this talk, we can simplify everything and have a more concise and precise thought process. So these are some of the normal structures that we'll go through today. Let's start with the lobar anatomy. So to figure out exactly which part of the cerebral cortex we are on, we need to know exactly where is the central sulcus. Now there are many ways to figure out where we are exactly. I'll just take two of the more common and my favorite ways to identify the central sulcus and share it with you guys. Now this is an axial CT scan. This is corresponding to a rather high cut on the sagittal scan beside it. Okay, so we can recognize this superior frontal sulcus over here. And we know this is the case because it's in the anterior portion of the axial cut. It is parallel to the interhemispheric fissure. And of course, it is right lateral to the superior frontal gyrus. So we have the superior frontal sulcus over here. The south side that is just posterior to it, in continuity, this is the precentral sulcus. And of course, we have the central sulcus immediately adjacent to it. So the question comes, what if there is a lesion in the frontal lobe, distorting the entire anatomy? So there are two main ways that I like to do it. Firstly, we can look at the contralateral frontal lobe to give us a clue. And another way we can go about doing this is by looking for the intraparietal sulcus. So this intraparietal sulcus, we know that this is it because it's in the posterior part of the axial cut. It is in oblique orientation compared to the interhemispheric fissure. This brings us to the post-central sulcus. And of course, what's anterior to it will be the central sulcus. Now, after we identify the central sulcus, we know for a fact this is the precentral gyrus. And that is because there is the hand knob over here. And this corresponds to the contralateral innervation of the motor function of the hand. Let's talk about the subcortical region. Okay, we see this structure over here. This is the head of the caudate. We know this because it is just lateral to the frontal horns of the lateral ventricle. Next, we can identify the thalamus. The thalamus is the superior aspect of the lateral wall of the third ventricle, which is just seen over here. Okay, and we can see the internal capsule right over here. Okay, we have the anterior limb of the internal capsule. We have the genu over here, which is just lateral to the foramen of Monro, and we have the posterior limb of the internal capsule. And just lateral to it, we have the lentiform nucleus. Moving on to the brainstem. Now, there are three parts. We have the midbrain, pons, and medulla, right? So we can identify the Mickey Mouse shape appearance over here. So M for Mickey Mouse, M for midbrain. Hence, this represents the midbrain. The pons is attached to the cerebellar hemispheres through the peduncles. All right, you can see the two peduncles over here. Hence, we can identify the pons. And lastly, we have the medulla. All right, we can see the foramen of Luschka exiting laterally, the Magenty in the midline, and that gives us the medulla. So very quickly about the ventricles, right? There are two lateral ventricles, one on the left, one on the right. We have anterior here, we have posterior over here. Now the Monro, whatever is anterior to the Monro, we have the frontal horns. Anterior to the Monro is the frontal horns, posterior to the Monro is the body of the lateral ventricle. This leads us into the atrium, which is in continuity with both with the Monroe, with the body, the occipital, as well as the temporal horns. Okay, so both lateral ventricle filters into the third ventricle via the former Monroe, and that brings us to the fourth ventricle over here through the aqueduct of Sylvius. So let's translate this to the axial CT scan. Right over here, we have the frontal horns. Okay, we have the atrium. We have the temporal horns over here. And of course, we have the former of Monroe. Now, before we move on to the third ventricle, it is very important to know how the normal ventricular anatomy looks like on an axial CT scan. So if you can focus on the frontal horns, you can notice that it actually looks rather like a deflated balloon, right? It has a concave shape, and anything that deviates from this, you should be very suspicious of hydrocephalus developing, right? So once the concave shape starts to round and balloon outwards, that is an early sign. The temporal horns as well is generally slit-like and not easily seen. So unlike this schematic we have over here. So once this temporal horn gets more and more prominent, that's another red flag as well. Now over here we have a slit-like midline structure, and this is the third ventricle. And of course we have the Sylvius and the fourth ventricle over here. Now finally, for normal anatomy, we can talk about the cisterns. Now of course there are many cisterns that we can talk about all day, but I'll just zoom in on the key important cisterns that we should all know about. Now right over here is the interpeduncular cisterns, sitting just between both cerebral peduncles of the midbrain. We have the crural cistern and the ambient cistern over here. In the posterior fossa, we have the cerebellopontine angle cisterns. And very important as well is the cisterna magna. So we have talked about normal, let's touch a bit about abnormal, right? So it is very tempting to just read scans purely based on pattern recognition. But I do find that tends to make me miss things. So I would recommend a system to be comprehensive and just very similar to how we read ECGs and chest X-rays. You know, there is a system that we can apply to CT brains. So personally, I like to use the ABCs of scan reading: A for asymmetry, B for the blood and brain, C for CSF spaces, and S for skull and scalp. So I'll read the scan multiple times, a very quick general screen, just purely looking for any asymmetry. Then when I look at the scan in detail, I'll look specifically for the B, C, as well as the S. Now, this scan here, let's just look at it from a very broad perspective. I think it's very clear to all of us that there is asymmetry. The right side of the brain and left side of the brain are clearly different. There is a large precentric lesion compressing on the brain, leading to shift of the midline, effacement of the ventricles over here, and some of the south side angiopathy that's prominent, that is still present on the contralateral side, is not seen over here. There is clear asymmetry. When we talk about blood in the scan, we talk about acute, subacute, and chronic blood. The more acute blood is hyperdense or bright. That's with respect to the adjacent cortex. Subacute blood, which is generally after 3 days old, will be more isodense, which is similar in color to the adjacent cortex. And we talk about chronic blood that's beyond 2 to 3 weeks, and that's generally hypodense or dark compared to the adjacent cortex. So right here we have blood in multiple compartments. We have blood that is lenticular in shape, lens shape here, and that is blood in the extradural space, extradural hematoma. We have blood in a concentric shape, and that is a large, a moderately sized subdural hematoma. There is blood here in the parenchyma, intracerebral hematoma. Of course, blood in the cisterns, subretinal hemorrhage. Blood in the ventricles, intraventricular hemorrhage. Not to forget as well, there's intracranial compartment, there's also the extracranial compartment. So there's this large scalp hematoma that we should not be missing. When we talk about the brain, sometimes you can see a very clear asymmetry in the appearance. Now for this axial cut over here, we can see a large hypodense lesion encompassing the territory of the middle cerebral artery. This spares the anterior and posterior cerebral artery territories. You can see the sulci and gyri on the contralateral side are still nice and open. However, ipsilaterally, they are effaced. Of note, the ventricles on the ipsilateral side are still wide open. So this is middle cerebral MCA infarct with mild to moderate mass effect. And you can see over here the culprit lesion. We have a dense MCA sign representing thrombus in the proximal M1. Now, we talked about ventricles earlier. Now, if you can zoom in on the middle axial cut over here, you can see that the normally concave frontal horns of the lateral ventricle has actually started to balloon outwards. Okay, and this is because of the extra CSF that's accumulated within the lateral ventricles. Likewise, the temporal horns that are initially slit-like have become very prominent. Third ventricles, it's now rounded, it's not supposed to be like this. Okay, also a very important clue will be these hypodensities that is just adjacent to the frontal horns, and that represents transepidermal shift of CSF that's pushed out the ventricles into the parenchyma, representing acute hydrocephalus. Now, the cystins are a very useful marker in a CT scan, because the cystins actually mark the boundaries between compartments of the brain, which means if there is cystinal effacement, there is likely to be some form of herniation syndrome happening. Now, if you look at this normal scan over here, you can appreciate around the midbrain, the basal cystins being wide open. However, on this image over here, the interpeduncular, bilateral crural cystins, as well as the ambient on the contralateral side, is all effaced. Why is this the case? You can see, I'm sure you can appreciate the uncus of the right temporal lobe herniating and compressing on the midbrain. And this is secondary to a large precentric lesion on the right side. We talk about the skull next. We can see a large extradural hematoma. And that is, if you switch on to the bone window, we can see that this is actually secondary to this displaced skull fracture over here. Now, finally, we talk about the scalp as well. You can see a scalp hematoma here, a scalp hematoma here, and that's about it. So two very quick tips in addition to being comprehensive is to play with the windowing of the CT scan. When we are looking at scans, we generally only see the brain window and the bone window. So if you look at this brain window over here, I think most of us can appreciate that there's some asymmetry, but it's not so easy to figure out what exactly is happening. However, if you look at the subdural window, we can see that there is a thin layer of acute subdural hematoma. So this is not seen in the brain window because in the acute phase, sometimes blood can appear to be of similar density to the adjacent skull. So we can use a subdural window to differentiate the blood and the bone. Another quick tip is, if you forget everything, at the very least, remember how to look for mass effect. So let's start with midline shift. So this is what the radiologists love to report. So let's figure out exactly what it is. So we can see here the midline of the skull. You can find this when you draw a line from the crista galli to the inion. So this is the midline of the skull. Over here, at the cut, where you can see the foramen of Monroe, we can use the septum pellucidum as the midline of the brain, and the distance in between will be the midline shift. If you go on to the scan to the right, okay, we can talk about effacement of a few things. Effacement of the sulci, which is still prominent on the contralateral side, and effacement of the lateral ventricles with the frontal horn and the atrium occipital horns being effaced. Finally, we talk about herniation syndromes. Uncal herniation, as mentioned previously. And if you look at this scan on the left, this is the cisterna magna. You can all appreciate these two ovoid structures here. They're not supposed to be present. These two are the cerebellar tonsils, and they have descended due to raised intracranial pressure in the posterior fossa, tonsillar herniation compressing on the medulla. So let's just go through a few real-life examples to apply some of the lessons that we have learned. Before that, so very often when neurosurgeons are called to see a patient, the scan has already been performed. And personally, what I like to do when I see a scan is I like to try to predict the patient's neurological status. And I find that it's very useful because not only it helps me in understanding the functional and the radiological neuroanatomy better, but that is also very important because I find that if I have an idea of how the patient might be doing, as I am going towards the patient, either in the emergency department or in the ward, in my mind, I'm already formulating a plan. Okay, and when I see a patient, I'm just trying to confirm the patient's neurological status and executing my plan. So there's no way to escape. You are the surgeon and you are the radiologist at the same time. Okay, so let's just go through a few scans. This is a scan of a middle-aged gentleman with uncontrolled hypertension. So the patient presented with acute right-sided weakness. All right, so if your answer for this scan is, you can see a left-sided thalamic lesion. We know this is thalamus because we can identify the third ventricle, and this is the lateral wall. There's a small sized thalamic intracerebral hematoma with probably mild mass effect. You can see the ipsilateral sulci and gyri still wide open. Now this intracerebral hematoma has actually dissected into the ventricles, as you can see. And if you look down at the temporal horns, you can see some early prominence suggestive of hydrocephalus. All right, so let's move on to the next scan. We have a patient who presented with acute headache and vertigo with rapidly worsening drowsiness. Okay, let's look at it one more time. All right, so if you look closely, we can all see a large intracerebral hematoma arising from the left-sided cerebral hemisphere that's causing severe mass effect in the posterior fossa. And we know this because the cerebellopontine angle systems bilaterally are effaced, the fourth ventricle is effaced, and if you look down into the cisterna magna, you can see the tonsils herniating downwards. And of course, as expected, there are early signs of hydrocephalus. This scan here belongs to an elderly lady with a history of multiple falls. She presented with another fall this time, and she has she's on aspirin for ischemic heart disease. Okay, so I'm sure we can all appreciate this lady. This scan has generalized cortical atrophy from the prominent sulcus. You might think that there may be some ventricular prominence over here. However, if you compare the proportion of prominence against the sulcal prominence, this is actually acceptable, and it's more of a part of aging rather than hydrocephalus. Now, if you bring the scan upwards, we can see a small crescentric lesion on left convexity, and that's a subacute nature because of isodensity to the cortex, and it's causing mild mass effect on, well, actually no mass effect. Now, final scan of the day, patient with acute headache and rapid drowsiness and right hemiplegia. This should be quite obvious to all of us by now. All right, we have a large intracerebral hematoma that's centered on the lentiform nucleus on the left side. This is causing severe mass effect actually. You can see it extending all the way to the cortex over here. You can see the sulci and gyri ipsilaterally being effaced. We can see the midline being pushed away. We can also see the blood dissecting into the ventricles. And of course, not to forget, the uncus is also compressing on the midbrain. Okay, so we've went through a lot today. We've talked about the purpose of a CT scan. We've talked about normal anatomy. We've talked about how we may find the central sulcus on the CT scan. We've talked about developing a system for not missing pathologies on the CT brain. And this is a very rapid review, so thank you very much for your attention. If there's any question I can help with, please ask. If not, you can email me. Thank you.
Razu, that was really great, but I'm going to take you to task on one part of your presentation. So I completely understand that when you've got a trauma, you're on the way down to the ED, it's good to look at the scan on the way to be ready. But in general, for your neurosurgical practice, you will do well to look at the patient first and the scan second. And that's particularly, we're coming up to spinal surgery, particularly in spinal surgery where you've got the 65-year-old woman where everyone's got an abnormal scan and you need to work out what is the pathology that's important. But it's, if you look at the scan first and the patient second, and I'm not disagreeing with you for an emergency situation, but if you look at the scan first and then the patient second, you really come with a confirmational bias of what you think is wrong with the patient. And that may not be the case at all. The patient with the narrow cervical spine, but who actually has Parkinson's disease, for instance, or a million other reasons why it might not be the diagnosis as based on the scan. So I'll let you do it when you're running to the ED, but not when you're seeing the patient in the clinic. Okay?
Of course, of course.
We have a question. Landmarks to use to measure displacement of the fourth ventricle for a posterior fossa extradural or cerebellar infarct? Must admit, I don't even know the answer to that question. I'm hoping that Dr. Rao might as well.
I think it's not so much landmarks, but knowing your normal anatomy and what gets distorted. So obviously, looking for foramen of Luschka and Monjondi and looking at the distortion that way, before looking at where the distortion happens anteriorly, prepontine cistance, cerebropontine angle cistance, and the final one is basically upward or downward herniation, right? So I think when you consider the pathologies that happen in the posterior fossa, you have to look at that sort of where is the effacement going to be.
And we've got a very wise comment from Dr. Al-Dradi from Yemen, just reminding us that when the patient has a trauma, they may have other injuries that need to be uncovered by examination before you make a diagnosis and treatment plan. But thank you so much, Jiazu, for that presentation. It was most comprehensive and incredibly useful. I might ask you to unshare your screen. Oh, wait a minute. I've got one more question. Do you think that only 2D axial images are sufficient or coronal and sagittal too are required?
That's with regards to mass effect, to finding a lesion. What exactly in particular we're talking?
Probably in general terms, really. I mean,
yeah. I think that one is, if you look at different hospitals in the world, depending on the radiologists, some of them are comfortable just reporting only on axial scans, and some would need two views, usually an axial and coronal view. Sagittal views not routinely done, I would say most of the time, but critical for you to reconstruct them based on the current CT methodology. So you can always ask for a reconstruction if you don't have that view that is given. I must say in our National Neuroscience Institute, our radiologists prefer only axial slices in terms of loading it up and reporting it. But some of the other hospitals do require an axial and coronal scan.
Okay, thank you, everyone. I think we'll move on. Otherwise, we could be here discussing this all night. So thank you, Jiazu. That was a great presentation.
I have small comment only, please.
I'm sorry?
Can I say a small comment only?
Yes, of course.
Thank you, Dr. Lim, for your very, very nice presentation. Just only a small addition. for the acute lesions you are having, if you are seeing some hypodensities inside or around these acute lesion, hyperdense lesions, we must predict that there is an active bleeding, because hypodensity in such patients, especially when I know that the history of the patient is just acute by trauma or by bleeding, that there is an active bleeding in that patient, which if I saw a small hematoma, by example, I should predict that this hematoma is increasing in size by time, and this patient will need either very, very close observation or repeat the CT scan in very short time. Thank you very much. Dr. Drummond, your note was excellent regarding that he should see the patient first and then see the CT scan. But if you saw the CT scan and you saw the patient later on, I re-advise you to go back and see the CT scan again.
Of course.
Thank you very much.
Yes.
Thank you, Dr. Zaidan. Okay, so we'll move on to our final presentation. We've got David Mack, who's going to speak on management of acute spinal cord injury.
Hi everyone. This is David from National Neuroscience Institute of Singapore. Thanks everyone for attending this talk. I'm talking about the management of acute traumatic spinal cord injury. So my talk really focuses on management of.
Do you want to go to presentation mode for your slides?
Oh, sorry. Okay.
That's great. That's great. Thank
All right,
you.
great. Okay, my talk really focuses on only the management of acute traumatic spinal cord injury. So I'm not going to talk about anatomy, injuries to the vertebral columns and ligaments, or other disease affecting the spinal cord, or chronic complications of spinal cord injury. So traumatic spinal cord injury is an epidemic in the modern society with peak incidence in young adults. So most common from road traffic accidents, and they often carry substantial permanent morbidity and mortality. Despite advances in the understanding of the pathogenesis and improvements in the early recognition and treatment, this remains a devastating event and often producing permanent instabilities. Now, spinal cord injury is defined as a damage to the spinal cord caused by an insult resulting in the transient or permanent loss of usual spinal motor, sensory, and autonomic function. We always talk about primary injury, which is irreversible, where the initial damage results from direct cord compression, hemorrhage, and traction forces. So common mechanisms are subluxation of vertebral elements causing cord compression, hyperextension injuries in falls, or retropulsion of bone fragments into spinal canal. On the other hand, secondary injury, which is potentially reversible, it happens within minutes after injury. Secondary damage begins. A hemorrhage, cord edema, and resulting cord ischemia, loss of autoregulation, and hypotension can lead to spinal cord hypoperfusion and the extent of spinal cord injury. Now, this diagram shows the key pathophysiological events that occur after primary injury, which leads to secondary injuries. So basically, vascular disruption, ischemia occurs immediately after primary injury that initiate glial activation, neuroinflammation, and oxidative stress. These acute changes result in cell death, axonal injury, matrix remodeling, and eventually formation of a glial scar. Next, I want to talk about neurogenic and spinal shock in spinal cord injury. So neurogenic shock is an interruption of autonomic pathways leading to hypotension and bradycardia and sometimes hypothermia. It's commonly seen in injuries involving cardiac sympathetics. So it causes a decrease in systemic vascular resistance, decreased inotropism, and an increased unopposed resting vagal tone. On the other hand, spinal shock is the loss of reflexes below the level of spinal cord injury, resulting in clinical signs of flaccid areflexia. Let's not forget, this could be combined with hypotension from a neurogenic shock and a hypotension from hemodynamic shock, for example, in severe polytrauma cases where there is volume depletion. Now, it's important to know about bulbar cavernous reflex because it is important to determine between complete spinal cord injury and the presence of a spinal shock. This patient has complete spinal cord injury, their recovery is going to be poor. So absence of this reflex is an indicator of spinal shock. So on the other hand, period of the spinal shock usually resolves within 48 hours. And this return of this reflex signals the termination of spinal shock. So you can know the true injury stages of the patients. Now, classification-wise, we use the American Spinal Injury Association impairment scale. It is recommended as the most consistent, reliable, and valid scoring system for these patients, and it is the international standards for classification. So it's grade A to E. I usually remember it's grade A being awful. It's a complete spinal cord injury. There's no motor sensory function preserved. Grade E is excellent. There's normal spinal cord, there's no injury. While B to D means incomplete spinal cord injury, while B means there's only sensory function preserved. For C and D, it's just whether the motor function below the spine level of injury, whether the key muscles below the level has a grade, muscle grade power of less than 3 or greater than 3. Now, the injury severity is the most consistent predictor of neurological recovery. So the ASIA score is important in the way that it prognosticates how the patient may recover. Let's look at this diagram. It shows that the ASIA A patients on presentation, less than 3% of them are ambulatory at follow-up, while ASIA D patients, up to 95% of them are ambulatory at follow-up. Now, mechanisms of spinal cord injury are usually as listed here: flexion injury, hyperextension injury, compression fractures, or flexion rotation injuries. There are we classify the types of spinal cord injury into, as I mentioned before, complete and incomplete. So apart from quantifying them into just paraplegia or tetraplegia, there are incomplete spinal cord injury types also, which is shown here. So there's most commonly described Brown-Séquard syndrome, central cord syndrome, posterior cord syndrome, and anterior cord syndrome, which I want to highlight. Central cord syndrome is most likely the more commonly seen type of incomplete spinal cord injury. It involves, it's caused by a hyperextension type of neck injury, and clinically, patients usually have involvement of upper extremities more than lower extremities, where it affects distal more than proximal muscles, and there's a variable degree of sensory loss. Reason being the alignment of the lateral cortical spinal tract, the upper motor, upper limb, upper extremity fibers are arranged more medially. Now, approximately 3 to 25% of spinal cord injuries can occur soon after trauma. So during either transport or early clinical management. So spinal immobilization is important for all trauma patients with spinal cord injury, especially for those with a mechanism of injury that has the potential to cause spinal cord injury. So effective immobilization includes rigid cervical collar and supportive blocks on a strapped backboard. Sandbags and tape alone is not recommended because there's limited effectiveness in restricting C-spine motion. So as I've mentioned, rigid C-collar and strapped patient on the backboard on the left side, as you can see here. So we manage spinal cord injury patients usually according to the ATLS principles, which is the Advanced Trauma Life Support Guidelines by the American College of Surgeons. So we go by ABC. A is the airway. We always try to first sort out the airway, maintain oxygenation. Let's not forget there's low threshold for intubation for upper cervical spine injuries. You can consider rapid sequence induction and manual cervical inline stabilization with minimal neck flexion. Our breathing, there's the next thing that is important. We always want to closely monitor patient and then at least a high dependency unit, at least for the first 72 hours. And of course, consider early intubation if needed. Circulation needs to be monitored. Let's not forget, in the initial stage of trauma, there may be immediate catecholamine surge resulting in hypertension and tachycardia instead of hypotension. So next comes to D, disability. We usually monitor using the American Spinal Cord Injury Association score, where you classify motor scores and sensory scores in a standardized fashion, so we can compare and contrast how the patient does during monitoring. Now, imaging for traumatic spinal cord injury-wise, there are usually two criteria you can follow. One is the Canadian C-spine rule, and the other one is the nexus criteria. I myself usually follow the nexus criteria because there's a mnemonic you can follow for patients who require imaging to clear. You can follow the mnemonic NSAIDs. So N for neurological deficits, S for spinal tenderness, A for altered mental status, I for intoxication, and D for distracting injury. So in other words, basically a patient who comes into you GCS15 alert with no midline C-spine tenderness, range of movements for the neck is active in all directions without pain, you can actually clear the C-spine. Of course, for current recommendation for symptomatic patients is a high quality CT of the spine wherever available, and we would like to view the axial, coronal, and the sagittal cuts to delineate the exact bony anatomy and relationship MRI will be useful to look at neuronal structures, and of course, intramedullary signal change on T2 sagittal-weighted sequences in the acute period post-trauma may also sometimes provide some prognostic information, as such seen on the diagram next to you. This patient may have a poor prognosis because there's indication of a severe spinal cord injury. As you can see, the spinal cord signal is quite widespread. Now, next, I'm going to talk about the potential complication or issues related to traumatic spinal cord injury, and divided into cardiovascular, respiratory, venous thromboembolism, pulmonary embolism, and other. Other means there could be pain control issues, pressure source issues, GI stress ulceration issues, paralytic ileus, and nutrition issues. Now, adequate blood pressure is critical in maintaining perfusion to the injured spinal cord and to limit secondary injuries, as we've mentioned. Guidelines currently recommend maintaining mean arterial pressure at least 85 to 90 millimeters mercury for the first 7 days after acute spinal cord injury. Let's not forget, patients with traumatic spinal cord injury may also suffer both from neurogenic shock as well as hemodynamic shock related to blood loss and other complications, for example, in polytrauma. So let's not forget to top up the volume with IV fluids, transfusion, or even pharmacologic vasopressors as needed. When, however, in polytrauma patients, they might have indication to go for other surgeries like abdominal surgery. It's important to remind the surgeons or the anesthetists that maintenance of blood pressure intraoperatively is very important to protect the spinal cord. Now, on the other hand, patients with multiple injuries also may receive large amounts of IV fluids. Of course, excess fluids can cause further cord swelling and increase damage of the spinal cord. So remember to monitor fluid administration, strict urine IO, and monitor the electrolyte levels. Now, the most frequently seen pulmonary complications after spinal cord injury are namely respiratory failure, pulmonary edema, pneumonia, pulmonary embolism. Because the incidence of these complications is highest with higher cervical injuries. It could be up to 84% for high cervical traumatic spinal cord injuries. Now, as you can see, the higher the level of injury, it may cause complete paralysis of respiratory muscles and paralysis of the diaphragm. So these patients have a very low threshold of intubation, and a lot of them may have apnea requiring mechanical ventilation. Now, let's not forget, even in a lower spinal cord injury, for example, lower cervical spine or upper thoracic cord injury, weakness of the diaphragm and the chest wall muscles may lead to impaired clearance of the secretions, ineffective cough, atelectasis, and hypoventilation. So these patients may also have respiratory complications as listed. Now, signs of impending respiratory failure includes increased respiratory rates, declining forced vital capacity, a rising PCO2, falling PO2 on the ABG. All these indicate urgent intubation and ventilation, and they also may require positive pressure support. Chest physiotherapy should be instituted as soon as possible. And let's not forget, these patients may also need frequent airway suctioning. Now, DVT is also a common complication after traumatic spinal cord injury because of immobility. It may occur up to more than 50% of untreated patients, with greatest incidence between 72 hours and 14 days. So don't forget to consider calf compressors for all the patients. And we should also consider low molecular weight heparin or even IVC filter within the 72 hours of injury if there is no other contraindications. Now, there's one specific complication that may happen. It's called autonomic dysreflexia. So in response to a noxious stimuli, patients with a high spinal cord injury may produce a sudden increase in blood pressure requiring immediate medical attention. Usually this is a more later complication of traumatic spinal cord injury. It could be a level T6 and above. If this is left untreated or unrecognized, it can lead to seizures, strokes, or intracranial hemorrhage. Treatment is simple. Immediately remove the noxious stimulus, for example, a blocked urinary catheter or impacted stools, for example. Now, I think you need to know the pathophysiology of autonomic dysreflexia as the diagram on the right-hand side. So basically, there's a noxious stimulus related to the spinal cord. There's a massive reflex sympathetic activation, including the splenic vessels, resulting in a high blood pressure. Now, baroreceptors from cranial nerves 9 and 10 detects a sharp rise in BP, it feeds back to the brain, where the descending inhibitory impulses were blocked at the level of injury. So there is a resultant very high blood pressure that's not counteracted. Now, neuroprotection strategies we've mentioned is to limit secondary injury. So as mentioned, we should always avoid hypoxia, hypotension, hypercarbia. Vasopressor support with to at least keep the mean arterial pressure for more than 85 millimeters mercury for 7 days in the first 7 days of spinal cord injury. Also to keep the blood pressure not less than 90. Prophylactic hypothermia is not recommended. Now, how about steroids in traumatic spinal cord injury? There are two trials, the NARCISS-2 and NARCISS-3 in 1990s and 1997. Basically, the conclusion is that there is no class 1 or 2 evidence to support the benefit of high-dose steroids. And its use is not justifiable in view of increased side effects, notably infection and GI bleed. Now, current consensus and guidelines, though, is by Dr. Fehlings in 2017 in AO Spine Journal. It does suggest not to offer a 24-hour infusion of high-dose methylpred who present more than 8 hours with acute spinal cord injury, and also not to offer a 48-hour infusion of high-dose methylpred to adult patients with acute spinal cord injury. But he did suggest, though, a high-dose methylpred can be offered to adult patients with within 8 hours of acute spinal cord injury as a treatment option. So moving on, after the patient has been stabilized, treatments options to consider first includes traction, halo, surgery for stabilization, closed and open reductions, spinal cord decompressions. There are a lot of choices, but it is not in the interest of this talk for the surgical treatments. But I think it is important to know about the timing of surgery in these patients. So from a biological perspective, persistent compression of spinal cord after primary injury is a reversible form of secondary injury, for which when treated early may translate to improved outcomes. So animal studies or laboratory evidence supports the theory of surgical decompression because it attenuates the secondary injury mechanism, and these effects also vary inversely with time elapsed since injury. There is this landmark paper by Dr. Fehlings again in 2012, the STASIS trial. It stated there's clinical evidence to support this hypothesis. Surgery for this traumatic spinal cord injury patients within 24 hours is better and safe. And better is defined as at least 2 grade of AIS grade improvement at 6 months follow-up. Now but then what is early? There are various different definitions for early. A lot of results have shown that interventions within 24 hours will provide the most significant outcomes. But let's not forget, patients with unstable fractures, dislocations, etc. of the spine should be stabilized as soon as possible. These are some of the examples of the papers, for example, by Dr. Marco in 2019, 2015. It suggested surgical decompression within the first 24 hours on neurological recovery is time dependent, and within 8 hours could associate it with better outcomes. So from biology and basic science perspective, early surgical decompression does make sense. Although most studies lack the statistical power to qualify as strong evidence, early surgery, if logistically possible, have not shown to cause adverse outcome and may even potentially be beneficial. So in summary, initial neurological assessment and Asia impairment scale grading are important components of acute spinal cord injury management. Now, high quality CT imaging, if available, is the recommended imaging of choice for cervical spinal cord injury patients. Neuroprotection strategies are important to prevent secondary injuries of the spinal cord. And close cardiopulmonary monitoring with maintenance of cord perfusion is recommended to reduce morbidity and mortality in these patients. Thank you very much.
Thank you, David. Another fantastic summary. You three guys, you're real stars. We've reached at one point 100 participants here, so clearly you're drawing the crowds. So we've got a couple of questions, and I'll also introduce Colin Nolan, who is the mentor for this presentation. A question about for patients with spinal cord injury who need intubation, how long do they need to remain intubated? You know, and when do you extubate? Now, this is obviously a difficult decision-making process. But what would you say, David?
I would say initially, if it's a high upper cervical spinal cord injury, of course, the threshold of intubation is low. And during the polytrauma, the patient will have been intubated. But if you talk about when to wean off extubation, I think there are a few factors. First is a neurological assessment, neurological factor of how severe or extensive the spinal cord damage is done, or what the spinal cord injury is. So maybe at some stage, an MRI scan may be useful to tell us the extent of the exact injury, the levels that is involved. On the other hand, when patients are intubated long enough in the ICU setting, the ventilation requirements, the oxygenation, basically the oxygenation ventilation requirements may be complicated by spinal cord injury also. And also they may develop other complications, including pulmonary pneumonia, etc. So all these may come to play as a factor deciding whether the patient is safely be able to be extubated or not eventually. So I would classify as neurological or ventilatory requirements associated.
And some may never be extubated. They may just be converted to a tracheostomy, of course.
Correct, yes, yeah. So some of them may be converted to a tracheostomy, which I didn't cover.
You've got a comment on that?
Yeah, no, I think the decision regarding the duration of intubation is really expectant, and we have a fairly low threshold to convert to tracheostomy in patients that we're worried about.
And then Yutung Lo has asked, how strong is the evidence for vasopressor support for maintaining a MAP above 85 millimeters of mercury for 7 days?
I would say the main thing is really to two components to look at. One is the volume status of the patient. The other thing is, of course, inotropism. So one thing is to drive the mean arterial pressure up. The other thing is, let's not forget, the patient may also have a deplete in volume in polytrauma situation. So sometimes not just a vasopressor or inotropes. Transfusion or volume fluid replacement is also important to drive the blood pressure to maintain the cord perfusion.
Do you know of any evidence for that, though? I mean, I'll ask Colm to comment, but I mean, I guess I would extrapolate from the head injury situation where there's actually pretty good evidence from big series that even a single drop in mean arterial pressure below normal can lead to a change in neurological outcome. So I'll probably extrapolate from that. But Colm, any comments?
Yeah, I think there probably isn't strong evidence for continuing the vasopressor support for 7 days. I think the first couple of days are probably more important, first 24, 48 hours, and particularly patients who are having surgery. When we talk about doing early surgery, I think, people say it has been shown to be safe, but obviously it's important perioperatively to maintain the mean arterial pressure of at least 80 to 90 millimeters of mercury.
And then a question from Calvin Lee, which, I think is an extraordinarily vexed question, depending on the setting that you're in, regarding early surgical decompression and stabilisation instrumentation for unstable spinal cord injury. May I know how often it's done in your centres? And I mean, I'll preface this with, having visited Africa on many occasions, and pretty much everything will fuse if you immobilise it, even externally, in young patients with spinal cord injuries like this. And so I think a lot of people worry that they've got to have some fancy equipment or very expensive screws to treat spinal cord injury adequately. But I point out that quite often the decompression is the most important thing. And in young people, much will fuse in a good fitting collar or a brace. But of course, that may lead to long periods of immobilisation. So instrumentation may be an advantage there. But what happens in Singapore?
Yeah, I think for our centre, we're quite lucky. We've got very easy access to MRI scanning 24 hours a day and quite easy access to the operating theatre. So we try to perform surgery within 8 hours if possible. So we've kind of subscribed to some of the newer papers that show there may be additional benefit to decompressing within 8 hours. So that's what we aim for. But again, it's very dependent on the setting. In Singapore, it's a very small country, so patients are brought to the hospital very quickly, and we can treat them very quickly. But it's really depending on the local setting in each country.
Would there be a cutoff time when you wouldn't bother decompressing?
Oh no. I think we would decompress all the unstable injuries.
Okay. Well, it's midnight in Australia. I'm sure the rest of you are having a much more civilized time. But look, I'd like to just say that this has been a really, really great night, or what is it, afternoon for you, evening for you guys. I think fantastic presentations of really good basic knowledge that everyone should have. Thanks to Wan Chu Sao for conceiving these neurosurgical boot camps, president of the Asian Australasian Society of Neurological Surgeons. Thanks to Warralux for being additional panelists there. Thanks to Colum and Jai for being senior mentors of our 3 fantastic young presenters who did a great job. And thank you for attending and asking some questions. And I think we're back same time next week for 3 further presentations. So I'll be looking forward to more than 100 attendees. Who have I forgotten? Oh, and John Bennett, thank you for putting this on Neurosurgical TV. We're all TV stars now. That's fantastic. So good night, everyone.
Good night. Good night.
Good night, everyone. Thanks, Kate.
Bye, everyone. Good night.
Bye.
Thanks, Kate.
Yeah.
Bye.
Thanks.
Hey, Dr. Warlock, thank you so much. John, thank you so much for having us. And yes, guys, great talk.
Thanks,
John,
Cecile.
you're muted.
Oh, thank you very much. It was
Thanks,
great.
John and Colin. Thanks, everyone.
Thanks, Dr. Colin.
Thanks.
Thanks,
Yeah,
Dr. Chow.
thanks everybody.
Thanks, Mrs. Young. See you tomorrow at work.
You make Cheers.
So equals today. Good.
Okay, guys, great work. Yeah, thank you for doing up the talks much better today. Thank you.
All right, thanks.
Yeah, John, I make them redo the talks.
Hey, Wayne, it went good. Can you hear me?
Yes, yes.
It went well.
Yes, it went well. Thank you so much for hosting, and Warlock Stu for helping us out in this.
Well, I think you may have hit an area where we need it, real basic stuff,
For sure. Yes.
Yeah. So I think you're the only one doing that really now. So
Yes.
a lot of people came.
Yes, we're happy for that.
Yeah, a lot of people today. I think it's more than 100, and really interact.
It stops at 100. We could have got more, but it stops at 100.
Right. It's okay. I think you can just put it up on the channel, and people can actually have a look at this, and we'll get the boys to do some more. I think it's they decide what is the topic they want to present.
Oh, okay. Well, that's good. We're gonna edit these videos. They'll be ready probably in about 1 or 2 days.
No, don't worry. Yeah, just put them up on Neurosurgical TV, and we look forward to them.
Okay, very good. Very good.
Okay.
Let's keep
Thank
rolling.
you. Yes.
Bye-bye.
Thank you. Bye-bye. Bye, everyone.
So your internet stable now, John?